the recording and change the presenter. All right, so you're the presenter. And you're on air, you're good to go.
You're on air, you're on air. Okay, so what I thought I would do as an introduction to framework is take you through the whole rationale for it. So this isn't a real tight value proposition type thing. It's the background and it's the basis for what I believe the value proposition is. Okay. So I think it'll give you some perspective for opportunities to condense this down into the 2-minute, the 5-minute, the 15-minute pitch, whatever that is. So when I talk about this, particularly to senior executives, I approach it from the perspective of, what's the big problem you're trying to solve, and then bring it down to specific problems that we could help solve. So if you look at the big picture, you have obviously healthcare transformation, huge changes in reimbursement, structure of the industry, radical changes from the way things have been done over the last 20, 30, 40 years or so. So that's resulted in the need for very significant changes, and the ability to do them quickly, in a lot of cases is going to be the difference between success and failure. Healthcare information, huge amount of investment in core operational systems, particularly on the clinical side, the revenue cycle, finance, supply side. Those are the kinds of investments that you can't walk away from. The switching costs are very high. Those systems are in there for a while. At the same time, they don't necessarily do everything that you're going to need to do to cope with that transformation, because they were effectively built for a fee-for-service world. They've evolved over the course of decades in many cases. So you're going to have to work with what you have. You switch those systems over time. Technology moves very quickly. It moves much faster than the systems that you're implementing for healthcare. That cuts both ways. That's a huge advantage in terms of being able to take advantage of technology, but that technology is only being absorbed so quickly by those systems. So the question is, how do you work with what you have in terms of your healthcare systems infrastructure? How do you take advantage of technology? And what are the kinds of problems you're trying to solve? What are the approaches you can take to that? Reality is that you're going to have a lot of problems that are going to fall in between those systems, those key operational systems. Analytics is very well positioned to deal with that, to help you derive value between and across systems. That's kind of the key premise in terms of where analytics fits in. In terms of how the industry is approaching solving these problems, this is the triple aim triangle from the Institute of Health Improvement, very well respected organization. This is Don Berwick's group. Very successful actually throughout the world as well as within the U.S. in terms of affecting change in healthcare to improve the healthcare process. And these are the three areas that are in effect the balancing measures. So you have the health of the population, quality and safety. So the healthcare system is now all about ensuring high quality, safe care. So you have measures of health and safety, health of the population, kind of at the macro level. You bring that down to individual hospitals. You're talking about things like quality measures and outcomes. Per capita costs, what does it cost to take care of a person, not necessarily just a patient, but a person over the continuum of care over the course of their entire life. And then the experience of care, from an individual's perception, how well are they doing? How well is the healthcare system treating them? But more importantly, how are they functioning? How are they feeling? So those are the three measures that are ultimately being used to measure how effective healthcare is. And this is the ultimate goal, to affect change that moves the needle in a big way. So this is actually an example from IHI. The study was done in England, where they have nationalized healthcare systems, so they're able to kind of mobilize process changes because of the nationalized system. This was an example of how they were able to meet a goal of reducing hospital standardized mortality, which is one of the measures of health across a population, by implementing very specific process changes, doing it in a very coordinated way across many hospitals. So they were able to drive down hospital mortality through these process improvement measures in a statistically significant way over the course of 5 years or so. So ultimately, that's the goal. And the big question is, how do you improve healthcare? How do you measure that improvement? The challenge is, how do you do that? How do you do that across systems, across domains of data, across hospitals, across people? Very complicated problem. So shifting gears over to healthcare information, this is my perspective based on what I've seen in my experience in terms of what healthcare information looks like. So at the base of it, you have administrative, essentially claims-based information. This is the financial transaction data that basically makes the current fee-for-service system work. This is kind of the base of the pyramid because it's actually very good data because it's used to affect the exchange of money between parties, primarily payers and providers. On top of that, you have operational data, which is derived from the business processes and clinical processes throughout the healthcare system. Then at the top, you have the really good, really valuable information, which is clinical information. Now here's the challenge with those three domains. At this point in time, and for the probably next several years or so, you have the reason that administrative information is the base of the pyramid is that it is your foundation. It's really good data. It's by and large, it's reliable. It's used by commercial payers and the government, not just for payment, but for quality measurement. So you think of clinical quality measures, it's used by and large, or they're affected through claims-based information. Not ideal, but that's the way it is. And if this data is wrong, there are consequences. There are financial consequences in terms of not getting paid correctly. There are regulatory consequences in terms of getting fined or worse. So good data across these criteria of it's highly electronic, the integrity is very good for the reasons I described. The standards are pretty good, and it's complete information from the perspective of what it was designed to do, which is mostly get paid. Move over to operational data. So operational data is what's harvested from the transactional systems that implement the various processes within the healthcare system. So if you look at it across those same criteria, electronic, there are fewer paper processes than there used to be, but there's still some. So it's certainly on its way. Data integrity is only as good as the reason that the system was designed to begin with. So it may be really good. A surgery system might be really good for keeping track of supplies, but there are lots of other things that it's not very good at because the data integrity just wasn't designed to be there. Standards, not so much, because the standards don't exist in that world. Completeness, again, only as complete as it was designed to be. That very valuable information, but not as strong, arguably, as administrative data. Then we get over to clinical. Huge strides over the course of the last couple of years, largely as a result of the program that we talked about yesterday. So it's electronic. Well, 10 years ago it certainly wasn't. 5 years ago it wasn't. Big change there. Data integrity, still so-so. The nature of the data is somewhat counterintuitively. It's not nearly as good as you would think it is. It's only as good as what gets put into the system. The standards either didn't exist or were not being implemented in most of the mainstream EHR systems. That's changed fairly radically, but it's changing on an incremental basis.
So George, just to be clear, is this our view of the world, or is this?
This is my premise in terms of where we solve the problem. So this is the type of data that we can use in an analytics environment is limited and gated by these characteristics.
So if they come to us and say we have an administrative problem, pretty easy to deal with. Operational, marginal, clinical gets much harder.
Yeah, I'll get into that. But the working premise is that you work with what you have. Now, you can look into the future for clinical data, and life is going to be good 5 years from now. Practical reality right now is it's only really been a couple of years since the standards have been available. The systems have implemented those standards, and the provider users of those systems have begun putting data in that conforms to those standards.
Got it.
So today, not so much. Tomorrow, different. So this is Dr. Farzad Mastashari, who is the last administrator of the Office of the National Coordinator within Health and Human Services. He was responsible for Meaningful Use program. Actually did a pretty good job. But during his remarks as he was departing, he made the comments relative to analytics is that clinical data, which we've worked really hard to get to with meaningful use, is going to be great. Future tense, right? It's not great right now, but that doesn't necessarily mean that you can't start with what you have. So that base of administrative data, at his point, even though he's the guy focused on getting clinical systems, EHR, implemented on the front lines through these government incentive programs, his point is that, look, work with what you have today. You have this administrative data. There's a huge amount that you can do with it. So move over to problems to solve in this world. So if you go all the way back to this first slide, the transformation in healthcare is significant. So we already start solving those problems. Well, these are some of the big ones, and I think the research from Dresner Catherine kind of reflects this. So one of the big imperatives: drive down costs, drive down per capita costs. How do you do that? Well, you get people out of the hospital for one thing, but when they're in the hospital, what are your biggest costs? Where are your opportunities to drive down costs? Labor, significant, somewhere in the order of I think 60-70%. So staff productivity is huge. Internal labor-driven processes within the hospital, not particularly efficient. Service line profitability. A lot of hospitals and a lot of health systems, the difference between negative and positive margins rests in their surgical service line, which is becoming increasingly competitive. What can you do a hip replacement for? What can you do what's the other thing to replace? Knee replacement for. High volume operations, very competitive. The difference between contributing to the bottom line, not contributing, is all about service line profitability. That's all about efficiency and utilization in a lot of cases. Talk more about that in surgery and why surgery advisor is so critical in this area right here. Supply chain optimization. Supply is number 2 costs, I believe, between labor. Supply chains within a hospital, not particularly efficient. Coordination of care, patient flow optimization, getting patients through the hospital, population analysis. So there's a variety of different problems. Some of these have bigger price tags associated with them than others in terms of their ability to contribute financially and hit that triple aim. There's a couple of them that stand out. Government gets into the game here. So this is the CMS value-based purchasing program, which is one of a variety of different programs that are driven by CMS, the Centers for Medicare and Medicaid systems, which are the 2 big payers. They're the federal insurers. So they pretty much call the shots, and in a lot of cases the commercial payers follow suit. This is one of the pay-for-performance programs. It's called value-based purchasing. So where the system or where the program stands today is that there are measures of efficiency, process of care, outcomes, patient experience, and several more will be added over the next year or so that focus on cost and additional outcomes measures. Now, you can see within this group, so a lot of this information can be derived from claims information. So back to Dr. Mastashari's point, there's a lot you can do with that information. The government's already doing a lot with it, and they are measuring you. So if you don't know what's going on in this world of your administrative data, CMS and probably your payers are way out ahead of you. So they have more information on you than you have yourself because they're pretty good at data and understanding it. So this is kind of the ante to play. Now, some of this information actually comes from outside of the realm of clinical administrative information. So you start looking at experience of care. That comes from survey instruments, which are not only not administrative and claims information, but they're done by external firms. So that is external data. So there's lots of things that actually need to be combined together to get perspective, just to help you understand how the government's measuring you. Forget about your own internal measures. So shift the perspective over to your sources of information, your transactional systems that implement these processes. So yeah, in the middle you have hospital EHRs, you have your Epics and your Cerners and your Meditechs. Then you have, but that's only a limited number of settings of care. That's your hospital setting of care. Then you got your ambulatory EHRs. Well, the whole idea is to shift care outside of acute care facilities, in other words, out into the physician office. So this is kind of where the action is right here. And granted, Epic and Cerner have products that play in that space, but the vast majority of care is being delivered by independent private practice physicians who are using systems that are, I mean, they're more and more connected to the hospital world, but they may or may not be using the same technology, right? So those are the two core systems in terms of patient clinical information, revenue cycle information in many cases as well. But look at all the other systems here. And these are and if we kind of transpose those important problems onto these systems, almost every one of them requires information across those systems. So number one, staff productivity, right? So how do you measure staff productivity? How do you monitor it? How do you understand whether your productivity is good or bad? That probably involves 5 of these systems, right? EHR, revenue cycle, human resources, payroll, time and attendance, benchmarking data. And we've done this several times. We know this world pretty well. So, and you could probably add in at least 2 or 3 more. You can make the argument that a good productivity system probably hits each one of these in one way or another when you start considering budgets, benchmarks, patient satisfaction for balancing measures. So big problems don't get solved with a single system. Big, high-impact problems don't get solved with a single system. So the solutions to, as I just mentioned, some of the most important challenges, arguably the most important challenges, kind of exist between those systems. In other words, you're not going to be able to solve the problem within a single system. And even when you have a problem within the domain of a single system, there's pretty extensive transformation to that data necessary to get to useful information. We've actually seen this firsthand as we've kind of crawled into the Epic space. The most basic measures, right? The most basic measure of hospital activity, at least with respect to patient encounters, is a discharge or an admission, right? You think that would be pretty easy to get to, right? You got really experienced people working with really experienced people on the other side, tearing their hair out to get to a reliable, enterprise-wide reliable definition of a discharge. And it only gets harder from there, right? Because you want to stratify your discharges into acute, various levels of non-acute. You want to segregate that into service lines and payer classes and all kinds of things. So even within a single system, it's hard to get to useful, actionable information. And the reality is that the solutions to those big dollar problems are inherently complex. There's no way around that. But at the end of the day, it's all about getting the right data, right people, right time. Very simple concept. In reality, hard to do because of that complexity. So where do you start this seemingly impossible problem? Well, based on our experience and having done it in conjunction with big and small provider payer organizations alike, there is a way to do this. First of all, you got to break down the problem. You got to solve it incrementally. This is kind of our knock against the enterprise data warehouse. You got to pick a spot and dig in and show results, do something useful. Focus on user-oriented problems. You're not going to solve a problem if you don't know what the problem is to begin with. We got feedback from folks that have done the build it and they will come approach with enterprise data warehouse, and what they realize when they're all done is that they're really not solving specific problems. So those problems are very difficult to solve with the data that they've made available. Go where the value is. We saw that there's a handful of applications that have outsized return associated with them. Look for the low-hanging fruit. Back to polish the stone. There's a lot you can do with fairly readily accessible information. Let the user community guide your efforts. They're the ones who are actually getting stuff done in front lines as IT. Don't try to make the decision in terms of what the most important problems to solve are. And deliver early and often, which we have the opportunity to get very good at. Show good impact very quickly and then increment on that success. So how do you go about it? So this is the DI approach to breaking down, organizing, and solving those problems. So it's about the complexity in a way that introduces simplicity and consistency in the process, as well as how that information is delivered to the user. And we see analytics applications basically being separated out into three different realms: business rules, data sources, displays. And you need all three of those. You have to address all three of those to solve a complex, non-trivial, complex analytics process. So starting with data sources, and we talked about the need to take information from multiple systems, combine it together. That's a complex problem in and of itself, because data designed for different purposes by different people in different ecosystems tend to not go well together. Even standardized data, there's challenges. As you get outside the realm of standardized data, it gets that much more difficult. Normalizing data so that it makes sense when it comes together. These are big challenges, so non-trivial right here. So the first problem to solve is figuring out how to combine data and then how to transform data within single systems so that it at least makes sense to the point that you can begin to apply logic to it. Business rules is one of the big differentiators in terms of trivial versus complex analytics applications, in that if you really want to get the meaningful information, it's probably going to require producing measures that are complex in terms of the definition, in terms of the data that they require, in terms of the context that you're going to use to present them to users. That is a realm unto itself. So this is an area where DI is focused, and we've learned and worked through working in healthcare that this is one of the key problems to solve. If you're going to build useful applications, analytics applications, to solve these non-trivial problems, you have to conquer the business rules. Without getting a lot into data governance here, one of the essentials here is to do this in such a way that there's credibility of the information. And as you get into complex business rules, you need buy-in to definitions. You need the ability to validate those definitions, the implementation of those definitions against the intended use of that information. And it's arguably easier to do it in one department, in finance, for example, but the folks on the clinical front lines don't believe that number because it's a completely different number from what they use. So kind of the reconciliation around what's the right number, what does the number mean. In some cases, when you work through the issue, you find that there are different variants for the same measure, but as long as everybody understands that there are different things and those things are going to be used for different purposes, it's okay. But that's the big data governance challenge. And the classic issue there is a financially oriented measure versus an operational workflow measure. And you see the shouting matches between the folks on the front lines of the emergency department and the bean counter saying, look, I know exactly how many patients came through my ED. And the financial folks say, well, our charges indicate otherwise. Well, the reality is there's a whole bunch of non-chargeable activity. There are charges that kind of move out of ED encounters because the patient's admitted, they become an inpatient. All that data moves over to the inpatient. So completely different perspectives on the same information. One of the many reasons that it's complicated. The only way that this information is useful is if it can be used by end users who can consume it, do useful things with it. So presenting the information, delivering the information is, everything else is for naught if you don't do a good job. So this, again, is the ante to play. But the value of that delivery and display is largely dependent on those things that the user is never going to see because it's under the covers. So if you do all these things right, you have a reasonably good chance of building an effective and valuable analytics application. Our argument is that if you ignore or don't sufficiently consider any one of those, you're going to essentially hamstring your ability to build an effective application. So, dimensional insights approach, and these are all placeholder slides. I don't really like any of them, but I wanted to put something in here to talk about. So we start with a technology infrastructure that we've developed over the course of 25 years and have focused on, which we've used to solve healthcare problems. So the complexity, the inherent complexity of healthcare problems has actually driven much of the evolution of the platform. And we can get off and talk about collection, assembly, delivery, the capabilities of the platform, and the fact that it's an end-to-end integrated environment, delivery tools. The advantages of that is fewer moving parts in the infrastructure, ostensibly the ability to build more cohesive, integrated applications because they're all designed to work together. Those are the technical arguments. The way that we apply this within healthcare is to use those capabilities and map healthcare concepts, including data, business rules, views of the outside world. In other words, how do you get this data into the system to begin with? What type of data is it? How does it go together? What do you do with it? How do you apply business rules? How do you organize it around into analytical models that users in turn can use in some useful way? And then, very importantly, how do you build in the operational control, the automation, security, the integrity that's important at an enterprise level, regardless of whether you're doing this at a small hospital, 25-bed critical care access hospital or critical access hospital. These things are just as important as a 10-hospital health system. You can't ignore them. So the ability to scale up and scale down with a platform is really important. So talk about this at a very basic level. So the idea of that healthcare framework, which is essentially the mapping of healthcare onto these platform capabilities, looks like this from the perspective of information. So we talk about the polishing the stone, the claims administrative information. This is essentially the base layer of that. These are the key concepts within administrative data. In fact, from the perspective of patient information, most of what you do in healthcare kind of sits on top of patient information. There's supplies and other things, but at the end of the day, it kind of comes down to a patient and patient care, and that's where the money's changing hands. So these are the key concepts. Pretty much everything revolves around a patient encounter, a patient visit, some interaction between a patient and the healthcare system across settings of care. This isn't just the inpatient acute care setting. This is outpatient physician office. So what do you know about, what do you care about encounters? Well, you have physicians and other providers interacting with patients. You have a workflow of the flow of the patient going through the system. What's happening to them? Where they are? Are they in an ICU? Are they in the ED? Where were they yesterday? You have information that you know about the patient from a clinical perspective, their diagnoses, their procedures, and again, it's still administrative information. We're not even into the clinical realm. These are byproducts, artifacts of the claims, financial claims process. Charges, huge amount of information down at the charge level that helps you understand workflow, helps inform what's going on to the patient in terms of how they're being treated and why. You aggregate that, and then the financial information, payments and balances, help you understand both revenue cycle as well as ultimately costs and profitability. You aggregate that information to the patient level. So remember, these are individual visits. To the extent that you have a comprehensive view of the whole continuum of care, which arguably you don't in most cases, but where you do, you can aggregate the information of patient encounters to get a much more comprehensive view of what's going on with the patient. So you know how much time they spent in the hospital versus physician office, preventative care, versus coming to the ED when they really shouldn't be coming to the ED, how much they're costing you over the long term, what their chronic disease patterns are, because you have this information over a long term. You can actually aggregate a picture of a patient and begin to segment them into disease registries or basically cohorts just with administrative information. Right? So no clinical information yet. Based on what you know from this realm, you have a huge amount of information to work with. So that's the base layer. That's the foundation of the framework. And you basically build on top of that. That in and of itself doesn't necessarily solve that many problems, but it gives you the opportunity to solve problems. So on top of that framework, which is the organization of the data, the ability to define and apply business rules, you start solving problems. So to the extent that these are non-trivial, complex problems, there's a few different ways to attack them. DI has chosen a subset of those problems that we consider to be high value, amenable to being solved as analytics applications that are consistent from setting to setting to build solutions, applications for customers that in effect plug into that framework and share information in both directions. So to the extent that you implemented that base layer of administrative information, you have a starting point for building a solution. Now, you probably need to add information to it, but you have that base layer to build on. Now, the business rules and the other components of a solution are integrated into the framework in such a way that information, let's say measures that you produce in an application, PPA surgery is probably a good example, actually can travel back down through the framework and be used in other applications. So you'll think of it almost as a backplane where you produce something of value over here, you move it through the framework, and it's available over here. So when we transform data to get to a very complicated measure, so you saw examples yesterday in meaningful use of just how complicated those clinical quality measures are. You probably don't want to do that in more than one place. You do it in one place, and you make that information available elsewhere. So if you were to compute clinical quality measures with meaningful use, for example, and then in turn incorporate that into the physician performance realm, that would be an example of using meaningful use to produce the measure and then consume it within PPA for a completely different purpose. So, and the fact that that information is available essentially in real time or within a day or so is a big advantage versus the alternative of sending that information out externally and then having to wait for it to come back. So this is another way, again, this slide is not the ideal slide, but kind of makes the point that you start with the capabilities of the platform, which are all important. You layer on top that organization of standard data, and then you layer on specific solutions to problems at the application layer. And the other point we make is that these are the DI healthcare family is a subset of problems that need to be solved. And it will certainly never be so comprehensive that it's going to solve every problem. And some of those problems are going to need to be tailored to a particular organization. So we want to make sure that the customers are in a position to solve their problems still using all the capabilities of the platform, all the capabilities of the framework, and information that's produced by the solutions. So they have a huge head start, a huge starting point for solving problems that are going to be particular to them. And if we've done a good job, most of those problems are going to be derivative of what we've produced here anyway. Okay. This is a placeholder for a case we can make for our implementation process in terms of putting into practice what we talked about earlier in terms of focusing on specific problems, delivering quickly, and then incrementing on top of that. I'd have a hard time arguing that that exists in practice right now, but I expect that it will fairly quickly, and we can build a story around that, because I think that's one of our key competitive advantages, being able to move quickly ourselves, but also being able to transfer that knowledge and skill to our customers so that they can also move quickly. Okay, so that's kind of the pitch, or I wouldn't even call it a pitch. It's kind of the basis for the framework concept. So of course by now I'm sure you want to see what it looks like, right? So I'm going to take this from the perspective of the framework and what exists today in the framework, and kind of give you my version of the 10-minute high level. This is how we go about solving problems in the way that I described. So you can see that we've got this organized so that we can either go directly to the base healthcare framework or through any of the applications that we've built with and on top of the framework. So within the framework itself, and this really represents the base layer of the framework. In fact, in a sales environment, we use this subset to set expectations around that starting point, which is largely derived from the polish the stone administrative claims information. There are some examples that get outside of that, but most of the scenarios in here are derived from claims-based information. So we kind of make the point that you can solve a lot of problems with that information. Kind of has to exist to do the other things anyway. We've kind of learned that lesson in practice, where we've kind of dived into solving a problem that we didn't think required that base layer of information, only to go back and have to implement it anyway. So that's like kind of the voice of experience speaking there. So these are examples of our, you probably heard us mention the standard measure set. So this is a set of measures across these 4 domains. And there's probably somewhere in the neighborhood of 150 or so measures that represent kind of the starting point for that base layer. And the idea is to deliver this out of the box because it can be derived from standard claims data using standard information or standard business rules for the most part. And those, by and large, are rules that are determined by the claims process. In some cases, they're defined by CMS or an organization within CMS called AHRQ, Agency for Healthcare Research and Quality, who does the research and then in turn kind of sets the standards and measures based on that research. So what we've tried to do is confine ourselves to things that can be defined by well understood rules, AHRQ definitions, or in some cases just the standard uniform billing specifications that controls information that travels between payers and providers for claims transactions. So without getting into any detail here, you can see that each one of these is defined in terms of data sets, numerators, denominators, and ultimately business rules. Some of these are more complicated than others. By and large, these are the simpler ones. There are more complicated ones as well. So when we get into readmissions, there's a specification from AHRQ that tells you how the government calculates readmissions and readmission rates. It's very complicated. It's not as complicated as the clinical quality measures, but it's certainly non-trivial. But by and large, those can be computed, again, with that standard information, and it provides insight into outcomes information, which the government is using to measure. At the same time, you need that information yourself if you're going to control, for example, readmissions, which is increasingly becoming part of the reimbursement equation. So an example of how we would put that measurement data into practice and expose it to users. So I'm going to start with the kind of executive perspective, which is, if I am a hospital executive, CEO, COO, chief nursing officer, chief quality officer, chief medical officer, chief financial officer, there can be certain things that I care about. There can be certain things I care about a lot that I'm going to be watching very, very closely. So the idea here is to compile a set of those measurements that, based on your role, you care a lot about, and you want to understand how they're tracking, ultimately day to day, but at the very least, certainly month to month, to understand where the trends are as you go through a year, particularly where you've set specific targets or budgets, and you want to understand where you are across those. So this is the approach that we use to represent that information, and it uses the concept of a time frame. So we're looking at a calendar year to date, and we might have a fiscal year to date if that's the frame of reference. A actual or observed value for that measure, the target for that same period, so calendar year to date, actually based on completed months, then the variance of that, and then that's normalized to an index, which is a comparison between the actual value and the target value. So you can very easily look at any one of these to see whether they're within the target range or outside of the target range, and then in progressively more detail what's going on with that particular measure. So the two best demonstration scenarios at this point, they'll actually be more in time, are around average length of stay and cost, average direct cost, because they're one of the big drivers of operational performance. So as you can see here, across all of our facilities, average length of stay is outside of the target range. It looks like not necessarily for all the hospitals, but across the entire hospital system. Extensively, we have an issue, a potential problem with that. So there are a few different questions we might want to ask about that. So one is, what's the trend? Is this something that's just beginning to happen? Has it been happening right along? How does it compare to last year? So this is our average length of stay trend month over month for the calendar year. We can see that we're at least up over last year, so there's probably something to worry about there. So we can see monthly performance. Now, frankly, that can depend on a variety of different things. It's going to depend on the case mix, in other words, the patients you see in the hospital. So the raw length of stay in and of itself may or may not be particularly telling. So, of course, the next question I'm going to want to ask is, tell me more, give me the opportunity to understand what's going on with that better. So this is where we go from the transition from the realm of overall presentation to analytics and interactive analytics. So if I'm a chief medical officer, certainly a chief operating officer, this is my world. These concepts are the things that I live and breathe day to day. And one of the things that I'm going to want to do is to get down to the potential source or root of that problem. So what we've done in this particular analytics scenario is to choose a measurement, acute length of stay. This is actually overall length of stay, but we also have an acute measure as well, which gets into just eliminates hospice and rehab patients. But let's work with this right here. So if we take our target length of stay, which is based on a fairly granular benchmark that uses diagnosis and severity of illness at the patient level, we have an expected value for every patient. Now, does that necessarily mean we're going to hit that target for every patient? No, but in the aggregate, there's a lot of information to work with there. So we can look at and then if we aggregate that, so we can see here the difference between our expected length of stay and our overall length of stay, and the difference there between those doesn't really tell us that much. However, if we aggregate that on a patient level, in other words, the difference between expected and observed for every single patient, now we can determine our aggregate opportunity. And this is actually a net opportunity. The other way of doing this, which we do in PPA, is to take out the good performance and just leave the bad performance. This is on the balance, but it still gives us the opportunity to begin to look for where the challenges and opportunities are. So we can see at the aggregate level, the medicine department is an opportunity. No surprise there, because most of the patients are being taken care of within medical units. Surgery is interesting. Rehab's interesting. GI is interesting as well. In fact, GI is probably an outsized opportunity here. So, if we were to begin to look at the patterns within that data, the questions as a COO I might want to ask is, what are the patterns across the financial classes? Because there's going to be a direct impact of how I get paid by financial class. If there's a heavy concentration of those opportunities in Medicare, I'm not getting paid for extra days in the hospital versus commercial payers. I might be interested in further exploring that by probably diagnosis, or at this point I'm probably getting paid by my DRGs. So what are the patterns within the DRGs, and where are the opportunities there? So it looks like there's a high concentration in one particular disease category. We can actually get more specific than that because this information is at the patient level. We can go down to diagnosis, see if there are patterns there. Okay, there actually is. There's a concentration here. All right, who's doing what? We can look at attending provider, assuming this is a condition that's treated medically. All right, kind of distribute it out over several providers. At the same time, if we work with this group of providers right here who comprise, the majority of the volume within the GI group, there's an opportunity to make a difference there. So we can go all the way to the back and restart this from a completely different perspective. May turn out that there are procedures that are driving length of stay on this as well. The surgery area, there are certain surgical procedures resulting in patients staying in the hospital longer than as reflected by the data we want them to stay. So we could come at this from the perspective of surgery. So our major therapeutic procedures, no surprise, in general surgery, these are operating room procedures. We would expect that there's going to be a concentration of complicated cases. Let's look at this by performing provider, who would be the surgeons. So where's the opportunity amongst the surgical community? Well, here's one surgeon who stands way out. So we already found an outlier very quickly. Again, pretty basic data here. We're not into clinical data. We're not into data that's being derived necessarily by the surgical system. Straight claims data. What procedures is this physician doing? Do these procedures even make sense for the diagnosis? So let's say high concentration of small bowel sutures. Okay, what were the diagnoses for these? So as you can see here, we can explore this data in such a way that even at the highest levels of the organization, there's the opportunity to, first of all, maintain visibility across these measures, do in such a way that we can see across the realm of interest and responsibility what's going on, and then as necessary, progressively dig down, dive down, drill down into that information to get a better understanding of, is there a problem, where is the problem, what's the potential solution, or at least approach to solving it.
The links to take you to the analytics clients, are those going to remain there? Because I heard debate as that may not be there, which I think the functionality you have for the business user that would be engaging at this level, that it's not necessarily required, but I just didn't want to say they had access to a jumping off point if in fact they don't.
It actually doesn't even show up if they don't have those privileges and permissions.
Okay.
Yeah. So that's yet another religious war. My philosophy on this is that if you are capable of doing sophisticated analysis, regardless of who you are, you should have the opportunity to take advantage of the fact that you have that available, because otherwise you know what you're going to do.
That really goes back to the licensing changes. That
we're going to one single license type.
So it really doesn't matter.
It doesn't matter, but we need to spend some time and energy on what the viewer, the casual license becomes.
Right, okay.
But the difference between general and advanced, I do think we need a toggle, though, to keep people from getting themselves in trouble. If they're not capable of doing that, should we give
it to them?
This doesn't even show up if they don't have...
Yeah, but that's
under the current license structure.
Well, there's licensing and there's configuration.
Right.
Yeah, so we could configure it such that only a certain class of users even had access to this here. But this is... So there's two sides to this argument. One is that you're radically changing context if you move over to this view with within Diver. And I buy that. Right? You're going from one world to another. Now, the reason that you want to do that is that you have considerably more flexibility to analyze this information. So if you get to a point in that kind of analytical thought process where it's like, you got me to here and I'm really intrigued because I see something I either really like or I really don't like, but you kind of left me hanging, whereas the information is there. And the next step is kind of right there at your fingertips. So the idea here is that you move over into the more sophisticated analytics tool and basically keep your analysis going. The argument to not doing that is that this doesn't look anything like this, and you've kind of shifted modes. Yeah.
And there's about 10 different buttons that you could use to multi-tab and things.
Well, that's okay.
Anyone. It's a good capability to have, but you need to know what you're looking for.
And the fact that the consistency and user experience between these two isn't particularly there. There's a lack of consistency, so you're going from one world to a completely different world. I think that's a product issue ultimately that gets addressed, but right now, you're like, oop, what did I do?
Yeah.
You just got whiplash.
So are we creating problems for ourselves by having ProDive, by giving them even the option to do that? How many customers actually want to do that?
I think that's the question. Yeah, it's easy enough to take this out, and I think from a DI perspective, it probably comes down to which side of that argument you're on. At the end of the day, it's all about what the customer experience is. I don't know the answer to that from the most valid point of view, which is the customers. But I think that the need to do that is there based on my experience.
My gut tells me we're causing big problems by having ProDiver up there. If it says super smart people only click here, we don't have a problem.
Unless the dumb person
subscribes
themselves to the smart category.
Right, and then if they don't understand it, they know that they're, but you know what I mean? Like, if you say something like advanced analytics,
instead of the client name, you're telling them the capability that
advanced analytics,
be
that's
enacted.
Okay, because you go, okay,
you're like,
I'm not
I'm
smart
not the
enough
analyst,
for this, right?
Yeah.
Click, no. But, ProDiver, what's that? The other thing and we should discuss this, the ProDiver icon looks like I shouldn't touch it.
Don't even get me started on the
or
dive
if you're a diver.
I hate dive flag.
I get it. If we want to use a dive flag, we should have a little ring with a thing sticking up.
It's an international symbol.
This is easy
I
things to
can't
change.
even handle the dive flag commentary.
I don't want to dive deep into that, but in Europe, that means I can't go down that road.
It looks like the condemned. It looks like the condemned sign.
So,
well, interestingly enough, in this interesting story, when we asked John Hu for some help in terms of what icons would be.
It's like a circle with a slash through it.
Would be most appropriate to get to that, and I was kind of suggesting, without really saying it, why don't we just put the dive flag here? And he came back with this, and I'm like, well, it's not the dive flag, but actually, it kind of makes sense.
It's better.
Yeah, it's better.
It's better.
Yeah.
That I have no problem with.
Yeah.
And then if we had something like,
I think we just need to universally create an iconography standard that means something, regardless of your affinity towards and or understanding of the
frankly, the bigger issue here is that we shouldn't require our user to have to do that to begin with.
Right. Well, so I'm wondering if we're creating lots of problems for ourselves by having it there. Yeah. And then secondly, if we are going to have it there, maybe it just says advanced analytics, and then NetDiver is a different advanced.
The only difference between NetDiver and ProDiver is where it populates via the web or client. So, there might be some additional feature functionality set that's available in Pro that's not available in Net, but that's the gist of it.
I think the better solution to the problem is to provide more functionality within the diver format, and there's some that's already on the way. It'll be here within a month or so, to provide the ability to do more advanced interactive analytics just within this
Within
window,
the window.
which I think would get the executive user pretty much all the way to what they would want to do anyway. So there's less of a need to go there. The advantage of this is that it provides a context in terms of if I did want to get to the marker that was used to populate this view, this will take me there. There's probably other ways to do that.
I mean, but I would just call it advanced view, or something like that. So
I'm cool with whatever you guys come up with.
The most
savvy
would go, all right, cool, advanced view. Everybody else would click into it and go, nah, I don't think I want
to do that.
Well, there's probably even an opportunity to do that within this thing, within the dive report, an advanced view versus a basic view versus I go off to something completely different.
So we're at 11, and Fred's still not here, and we're supposed to start surgery advisor. So I'm thinking we should push surgery so that we can get through the completeness of this.
That's fine.
And let me just
let me go
let
see
Faraz know. Or are you going up? Or are you staying?
I think Faraz already knows.
Okay, I'll just email him. I'll be like, hey.
I'm going to go see what Fred wants
Yeah,
to do,
okay.
because I was supposed to be in the middle of it too.
Let me just shoot an email out of courtesy. And then we'll finish this up.
Is this what you're looking for, Lauren?
What?
The
Oh, the
whole
demo.
thing.
I was
No,
like,
the whole
yes,
thing.
it is.
Oh, okay.
It is. It's actually very helpful. Some of the functionality that I didn't think was available or knew that that's how it worked, it's helping me connect some dots. So. Surgery advisor. All right, let's keep it going.
On the recording, I guess I should show you.
Meeting, go. All right, awesome.
Okay. We live again?
We are. I can see you if it says on air in your tray. Then
Oh, am I on there? I guess I should check that one time ago. I assume I've been on there right.
I think you were at the beginning. Yep, I think you were at the beginning. So unless.
Okay, so the concept in the executive dashboard are kind of repeated as themes throughout the rest of the presentation layer, the dashboards. But let me show you a couple of different examples of how they're used. So the executive dashboard for a particular role showed a subset of measures or metrics that were of interest to that executive. At some level, you want to organize all of the measures associated with some category in the same place so that you can very easily look down through them and analyze or interpret them in various contexts. So right now, we're looking at the inpatient realm. So these are the measures. Again, these are base measures, starting point measures, derived from claims-based revenue cycle information. And this is a periods-based or chronological view where we're comparing similar periods. So year-to-date, month-to-date versus last month, current complete month versus the same month a year ago, or the previous month this year. For each one of these, we can do something very similar to what we saw on the executive dashboard. So we can look at that overview perspective to look at what the actual trend was over time. So this is reused between this dashboard and the executive dashboard. We also want to be able to get into that interactive analytics view. So although this is a slightly different version, because we're looking at a slightly different measure, so this is acute versus overall admissions and length of stay, same functionality, same idea.
Awesome.
So for each one of these, we have the ability to kind of explore the detail. So that's a chronological view. To the extent that there are targets or budgets available for these, this would be a subset of those in cases where there are budgets. So this provides a different basis for comparison. So this is our way of representing information that does have budgets associated with it. So we're actually showing the period over period variance as well as how that particular measure looks compared to its target. So this is a year-to-date view compared with...
Can you stay? Can you stay?
Yeah.
Okay.
Oh,
Sorry, George.
okay.
I've been being summoned.
Do you want
Keep talking.
Oh, keep
because it's
talking?
recording.
Oh, okay.
And
We're saying goodbye now.
Yeah, we're saying goodbye.
And Andrew.
So you have someone to talk to.
Look, I'm on the radio, right? Do you ever wonder when there's like two people on a radio show whether they're actually looking at one another, talking to one another, or just looking at the microphone? So I'm looking at the microphone and Kathy's. Okay, so this is our approach to representing information when there's a budget or a target involved. So we show the actual variance. So in the case of, let's use a ratio of length of stay. So we have a target value. So 3.8 is, or 3.97 is our target. 4.8 is our actual. So that represents a variance if we subtract the numbers from one another. 0.83, almost a day, which is pretty significant in terms of length of stay. But we also represent that as an index, which is the observed value divided by the target value, which in this case is more than 1, which is a bad thing. It actually puts us in the red zone. If we were less than 1.2, it would put us in the yellow zone, but we're more than that, so we're in the red zone. We actually flag the fact that we're in the red zone over there to easily identify measures that are in the warning hour, in the warning range, and that is all configurable by measure. So the idea is to be able to scan down through this column and see if there are any reds, and then scan down through where the lines are in this column to see what things you should be happy about and which things you should be unhappy about. Same functionality for all of these in terms of the ability to further explore information. So these were, so far we looked at key metrics in the inpatient area. We can also look at a similar set of measurements for outpatients and outcomes. Outcomes is significant because there's some very actionable information in this dashboard. So we're looking at specific disease populations, and in healthcare, the majority of costs go towards treating chronic diseases, particularly in the elderly population. So these are areas that we want to keep a very close eye on. So we can see our disease population, chronic disease population for congestive heart failure is significant. We can in turn look at our length of stay compared with targets. We can look at our mortality rates and how those compare with targets, and then also look at readmissions and various patterns within readmissions. So readmissions is particularly significant as it's part of the pay for performance and value-based purchasing programs. There's certain target readmission rates that are set by hospital based on their patient mix. If the hospital is above that rate or unfavorable to it, they begin to see penalties on their Medicare reimbursement. So these are these are examples of measurements that hospitals have become acutely aware of and have to manage proactively. Again, this information is all can be derived through claims information. Obviously, in order to get a better perspective on what's going on with something like readmissions, we probably want to understand this in terms of clinical data and operational data as well. So that takes us to a different view of the data. So far we've talked about measures that are derived from claims information. In the case of census, this is an example of combining claims information together with operational information. So the census, so this is the inpatient and outpatient in bed hospital census. So in effect, these are patients who are occupying a hospital bed. In some cases, they've actually been admitted to the hospital. In other cases, they're on observation status or otherwise have not been admitted to the hospital. So what's significant about this is that by capturing an hourly snapshot of this information, we provide a useful perspective on what's happening in terms of the flow of patients through hospital acute care facilities. So in this case, we have 3 hospitals in our health system. So we're actually aggregating our patient flow information across all 3 of those hospitals, which is giving us a perspective in terms of what's happening across the entire health system, in terms of where we are versus capacity, in terms of what our patient flow is in terms of patients coming in and patients going out. Now, one of the critical issues in hospitals is to make sure that we can get patients into a bed when they need to be admitted, but that in many cases means that we need to discharge patients, particularly if the hospital is reaching capacity. So discharging patients early enough in the day that the capacity is available for patients to be admitted is key, and we're able to see what our discharge patterns are. We can use this information to understand our admissions and discharge patterns across days. This is a particular day, hours within the current day, but we can understand that information from a variety of different perspectives and present that information such that we can understand, let's say, our discharge and admission patterns by hour of the day across a longer period of time. So the information used to create this view of the information can be used in a variety of different ways, such as looking at the patient flow on a particular day, understanding the trends, and then on that day understanding specifically what was happening at a patient encounter level. So in this case, this represents the group of patients who were discharged at that particular hour. We can further aggregate that information up so that we can understand trends over longer periods of time. And you can also go from the hospital level to specific units. So this is where things are going to get more interesting, because we can understand where our high volume units are, where we may be approaching capacity, for example. Let's see, I wanted to do details at the facility level so I can understand where our patients actually are. So this is a unit that we might be interested in, ATA. And we can see that we're actually down over yesterday. We're not approaching capacity. Probably a good thing. Okay. So that's an example of operational data that's being derived from an operational workflow process that we can use for a variety of different purposes. In this case, we're looking at perhaps efficiencies around the discharge process, and even understanding patterns of admissions by time of day, by day of week, by time of year. So as we collect this information over time, it becomes a valuable asset in terms of understanding, potentially predicting, and managing patient flow in the hospital. Okay. Another way to look at this information would be as it's attributed to physicians. So all that information, much of the information that we looked at so far, we've been analyzing and understanding from the point of view of an entire health system or hospital facility. We can also attribute these things to individual physicians. So if we're interested, for example, looking at our high volume physicians, and in this case we're looking at attending providers, so this particular physician, year over year, period over period, so let's look at a 6-month period and understand what's going on with these physicians. So it looks like this physician who we're focused on, Dr. Cardenas, is actually down in terms of his volume 6 months versus the prior 6 months. If we look at that from a historical perspective, 6 months versus the same 6 months last year, looks like maybe he's a newer provider, but in any case, there's a significant amount of activity here. Length of stay seems like it's going up as patient volume is going up. So there are some interesting things to look at. So in this case, we may want to look at Dr. Cardenas' information specifically. In fact, we may want to look at a specific group of physicians so that we can compare them to one another. So if we look at the medical service specifically, of which Dr. Cardenas is a part, we can begin to compare his activity amongst his peers. So we see that he has become the highest volume attending provider in the medicine service. So we may well want to take a closer look at his activity. So we've compiled this view using the information that we've used for other measures to get an understanding of what's going on. And it's very clear to see, as we arrange this information chronologically, that his activity in the hospital began in April of last year and has continued to increase month over month, except for this dip right here. So we understand the month-to-month patterns. We also understand his length of stay, his case mix, his revenue, average revenue. These are fairly high-cost cases, so some interesting things to look at there. Here, this is a profile of his practice based on diagnosis-related groups. We can see that it takes care of some very sick patients. To the extent that there are procedures, surgical procedures, and otherwise involved with the care of those patients, and the majority of them don't have procedures. We can see the nature of the other procedures. You get a more fine-grained perspective on the primary diagnosis of the patients that he's taking care of. Again, this suggests a lot of sick patients with high lengths of stay in many cases. And then finally, the distribution of his patient population by financial costs. Okay. And we can go back to our list of physicians, take a look at a different specialty, and go from there. Might be interested in our heart surgeons. And the procedures and the patterns around those procedures. Okay. So everything we've looked at so far is comprised of measurements, and typically we look at the details underneath those measurements within the context of a dashboard that's organized around a particular topic, such as an executive's role or a class of measures. In this part of the framework, we've organized the complete collection of measures by category so that they're searchable. So, for example, if I wanted to see any measure related to discharges or that have discharges in the name, we'd be able to see that, find and select that measurement. So once we have that, it's probably a bad example. It apparently doesn't exist. So we might be interested in looking at average length of stay. First of all, finding it or finding what our various measures of length of stay are. We've seen that we have a measure of acute length of stay. Here's the specific view associated with that information. So we're able to get to a marker, an organization of the data that is arranged around the data that's most pertinent to that particular measure. So a list of dimensions or classifications that are most associated or of most interest with regard to the acute length of stay measure, such as, let's say, for example, our performing physician. You might want to understand the procedure. But in addition to that, the model that contains this information will have a fairly extensive number of measures, or in dimensional insight terminology, summary columns. However, only a subset of them will be relevant to that particular measure. So we've selected the ones that are most relevant. So with respect to length of stay, or acute length of stay, we're interested in what the expected length of stay was at the patient level aggregated to this category, what the delta is compared to the expected level, what the acute number of discharges are, the percent of the population in that particular category. So we can see we have a concentration of patients with major joint replacements. See the case mix, which is a relative measure of resource utilization for these patients, and then the severity on a scale of 1 through 4, which tells us whether that group of patients is severely ill, which in the case of joint replacements, fairly routine, very low level of severity. However, we'll find that there are other patients that are on the other end of the spectrum. Here's a procedure on a patient with a serious infection. That's the highest severity level. And we can see that the length of stay is correspondingly higher, as is the case mix. So let's say that we wanted to do some additional analysis on that information. This is where we have an opportunity to move out of the dashboard environment into the realm of analytics. So this is the same marker, same columns, some additional controls. We're focused on the acute population at a particular hospital. I want to look at the entire health system. Now, another important point about how this information is presented. So the acute length of stay measure is summarized by discharge date. So we've selected the discharge date as one of the ways that we organize this data. The reason that we've done that is that if we use another time frame, such as the admission date, we'll get a misleading summarization of this information. So it's very important to understand the way that the data is organized and the appropriate way to interpret and analyze it. We've done that by choosing the dimensions that are most relevant, the time frame that's used in constructing and summarizing the measure, and in some cases some type of subset or filtering on the information to get down to the relevant subset of the information. So we're looking at acute length of stay. That only applies to the acute population versus the subacute populations. So it's important to provide the information in a context that's consistent with the way that the measures were designed and implemented to begin with. So the point is that that is all done for you with the analysis that you have available from the dashboard. So there's various other information that we might want to bring into this view that isn't available in the dashboard view. Let's say the number of unique patients we could bring into view. Whether patients were in the ICU or not. So we can build a view of the data that is consistent with what it is that we're trying to understand in this analysis. So, for example, if we wanted to analyze our ICU patients, bring that information in, then we also have the ability to dive into various types of information in a more extensive way than was available within the dashboards. The idea of the dashboard is to restrict that view to just the most relevant information. However, we can open up additional perspectives on that data for more sophisticated users that understand the implications of bringing that data in. So let's say, for example, we wanted to analyze this information in terms of chronic disease. So chronic disease tends to be one of the big cost drivers. So instead of looking at this information by diagnosis group, we may be interested in looking at it by chronic disease instead. So what we've constructed here is a classification or a dimension that combines together chronic disease or chronic diseases, the comorbidities in cases where a patient has more than one chronic disease. So let's say that we're interested in the subset of our population who has congestive heart failure as at least one of their diseases, because this is a big driver of utilization in the hospital environment, and also one of the conditions that are most responsible for hospital readmissions. So let's say that we wanted to focus on that cohort. So we can find a subset of patients who meet that criteria. So if CHF, which is the abbreviation for congestive heart failure, is in the list of chronic diseases, we're interested. So now we've created a subset, a group of those patients. So this is all patients who have congestive heart failure. So we can understand the characteristics of that population. We can also look at sub-classifications in terms of our comorbidities. So let's say within this group, how many of our congestive heart failure patients also have pneumonia, for example, or other more complicated comorbidities, and what are the incidence? What's the incidence of those combinations? So we can see that there's a high incidence of comorbidities of just congestive heart failure and diabetes, congestive heart failure and COPD. So we might be interested in what's going on within that cohort. So once again, we can get further down into the details in terms of the actual diagnoses of those patients, look for patterns there. Now, congestive heart failure is the primary diagnosis in some, but not all cases, because we built our chronic disease flag essentially around a registry of patients who have been diagnosed with congestive heart failure, which means that congestive heart failure can show up anywhere in their list of diagnoses, not necessarily just the principal diagnosis. So we've actually built a very valuable additional piece of information that allows us to navigate this information in interesting ways. In fact, using that, it looks like we've got patients who have a primary diagnosis of acute renal failure may be interested in looking at their entire diagnosis list. So this is actually summarized by the diagnosis codes, but if we know what the codes are for diagnosis, we can identify them through these lists, either by the primary diagnosis, which in this case would be renal failure, or the secondary diagnoses. And then we can move back up to our chronic disease population and continue to analyze that. Let's do one further look at this data. So it's already grouped together, but let's say we want to look at the cohort that has congestive heart failure, which we've already selected, as well as diabetes. Cut that part from the tape. All right. So let's say that we want to understand physicians and attending physicians who are taking care of these patients, to look for patterns there. So across the entire group of congestive heart failure patients, we can look at both our attending providers as well as our primary care and performing providers. And this is where we can look for patterns at the provider level in terms of where we might have discrepancies between expected and observed length of stay and opportunities to reduce length of stay. Okay. So the final point on the demonstration is really that everything we've been talking about in the healthcare framework is available to be used for analysis in the way that we've demonstrated. However, at the same time, that information can be used in a variety of contexts. So each of these other applications, surgery advisor, meaningful use, physician performance advisor, use that much of the information that we just reviewed to create new measures and associations. In the case of physician performance advisor, we're attributing provider care of patients by providers using these measures. So length of stay attributed to the attending physician for the patients that a particular physician took care of. So we're reusing that information. We're defining the measure once within the framework and consuming it in another application and presenting it in a context that is consistent with the goal of that application. Similarly, an application such as Surgery Advisor, which uses operational information from the perioperative system to create its own set of measurements, some of which are based on information from the BASE framework, others which are based on workflow information from the surgery environment. That information can be combined to produce additional measures which can in turn be shared back in the framework and used by other applications. So for example, surgeons could be measured based on measures that were defined and implemented in the Surgery Advisor application via the Physician Performance Advisor, which would determine the attribution of patients to the surgeons who perform procedures on those patients. Okay, I think we're going to call that a wrap.
Okay. Let's see if I can turn this